Hello, and I'm Doug Devries. I practice in Sparks, Nevada, and today I'll be covering this talk about MGD and no reason to wait to really empower your practice to start treating that. And legitimately, when we talk about no reason to wait, I think you'll see that with the accessibility that you have, with the demand that is there, there really is no reason to wait at this particular point, and really taking control of your patient's ocular health, particularly the ocular surface health of your patients. This is a promotional speaker program, and it's sponsored by Alcon, and I'm a consultant for Alcon, and we'll be complying with all regulatory commitments that Alcon has during the course of this presentation. So what I want to talk to first is really the prevalence of ocular surface disease. And what we're really figuring out at this time, it's much, much higher than we thought. And all of ocular surface disease encompasses some 64 million adults in the US with some form of OSD. And then when we subdivide that into the dry eye, we're seeing that number is somewhere around 35 million. And when we look at the number of people that are being treated, which we'll talk about a little bit later, we'll see that the tremendous potential exists where we can supply and we can do more help for our patients. Right now in the US, $3.8 billion is the annual economic burden of dry eye in the US. And when we look at it, it's complex, but it is so important. And when I say complex, it has underlying etiologies, it has comorbidities. And so we want to try to break this down is where can we get the maximum amount of efficacy for the effort put in for the patients. And what we're really trying to do with this ocular surface is help support the lids, the lashes, and the cornea, because we know that ocular surface disease can really alter the whole composition, distribution, and end up in resultant ocular surface damage. And that's what we want to try to avoid in our patients. So early detection is going to be very, very important. And we know that there's a tremendous amount of overlap in the symptoms of the various diagnoses, and that many patients may suffer from more than one form. And I think we all see this within our practices. So when we're looking at how essential the ocular surface, obviously it's the most powerful refractive surface on the eye in the whole visual system. And it's really composed of multiple structures, and each one of them has this integral part in making sure that we maintain clarity of that cornea. So it's with healthy lid margins and meibomian gland, absolutely we're finding more and more. And what's interesting, in the past, it was kind of an ignored part of the science. Now we're realizing, how this really plays such an important part and how we need to address this at an earlier point. So when we see the illustration of the meibomian glands, and I would venture to say, even myself specializing and really be, spending all my time, or the majority of my time, in ocular surface, 10 years ago, really were by and large ignoring these meibomian glands. And we were really focused on the lacrimal gland and the aqueous deficient dry eye. And now we're really realizing that this is a comorbid condition, that along that physiological continuum, that as you have inflammation, as you have increase in the inflammatory process, that then it causes secondary problems. And one of the problems becomes obstruction within the eyelids. So really maintaining the patient's ocular surface, it's a challenge, because what we have is a normal aging process. And then we have underlying conditions such as systemic autoimmune problems. We have medications that can be added that can exacerbate the situation. An example, we're now just starting to come in parts of the country where we're going to be coming into allergy season. And when we see that, another source of inflammation that can then be exacerbated by medications that we take for that. And then, of course, living and working in just dry environments that we have. And of course, what we've seen, especially during this pandemic, is we've seen that the amount of time that we're spending on any kind of light emitting device, any kind of digital device, and on these Zoom calls, as we see that increase, what we're becoming, the patients are so much aware, so much more aware of the stress that it puts on their ocular surface. And then, of course, we have ocular surgery, and whether it's refractive surgery, whether it's cataract surgery, we know that that's then going to put a stress, or if we have patients having blepharoplasties and we get incomplete lid closure. So, and then, of course, poor lid hygiene also plays a part in this. And we're becoming much, much more aware of what we're looking for, in that lid hygiene, and what we're looking for on that patient, looking for the prevalence of Demodex as well. And so really the lid margin is an incredibly important part of the tear film and the ocular health. When we see lid dandruff and crusty scales, when we see accumulation, and when we see formation of collarettes, and collarettes is so important at this particular point, because that really is indicative of some Demodex, which is an incredibly high prevalence. And as we go up in age, that prevalence becomes even higher. But when we look at that lid margin on the right, and we see those collarettes, we know there's also going to be a certain amount of staph in there that could cause some staph hypersensitivity. All of this ends up in creating more inflammation for that ocular surface disease patient. And a lot of times patients just aren't aware the impact of poor lid hygiene will actually have on their ocular surface health. When we take a look at AAO, AOA, TFOS really recommends lid hygiene to remove lid margin debris and biofilm. And biofilm is such an important concept that by and large has been fairly ignored over the years. And what creates a biofilm? Biofilm is created anytime we have bacteria, we have a surface, and we have moisture. Well, that just described the eyelid margin. You have bacteria, you have a surface, and you have moisture, and therefore you're going to get a biofilm. In any type of environment you have those three items, such as looking at a sink and a drain within the sink. When you look at different areas, you're going to get that biofilm. And when we look at the compliance that we have with having patients doing warm compresses, having doing lid hygiene, we know that it's fairly low. We know that it's somewhere around 45% of the patients are not. So, how do you really help your patients support good lid hygiene, and the emphasis that we can put on that for our patients? Well, there is something that Alcon has now, which is called Lash Cam IR. And what this allows is for the patient to actually be able to visualize portable handheld infrared with Bluetooth, so you can get a glimpse into the patient's eyelid health. You can really see, and this really helps the doctor to be able to look at these eyelids, and it allows you to really capture these images. It's real-time, high resolution, and allows these both the meibomian gland, the lid margin, the lashes to be visualized, and that really helps patients understand their condition and the need for treatment when you show them that. And we've said so many times that a picture's worth 1,000 words, and this clearly is one of those defining moments for a patient when they can actually visualize and be able to see what you're looking at through a magnified view. So this Lash Cam captures that very, very nicely. And then when we take a look and say, so what can we do with that? When we look at Microblepharo exfoliation, that is simply the removal of the biofilm, and it can play an incredibly important part. In my opinion, I think at some point within most practices, we're going to have lid hygienists. They're going to do this on a regular basis to support lid health and to remove that biofilm. Again, the biofilm is a matter of bacteria, a surface, and moisture. And what we get is this biofilm that then can actually affect the meibomian glands, affect the lash follicles, and eventually end up, as we've seen in a lot of cases with this, when you look, you just say those lids start to lose some of their we start to get laxity, and we start to see some tissue destruction in that. So I think that, as we look at a method that's an in-office procedure, the BluffX is something that I've been doing in my practice for years and years, very well accepted by patients, and they understand. The Lash Cam really helps them understand that as well, because they can see exactly what makes up their the problem and what's happening to their eyelid margins. And when we take a look at those pictures on the right. Now, this is you can see the same patients by the vessels on the eyelid, the before and the collarettes and the buildup around the lashes, and after a single treatment of BluffX. What you find is just a remarkable difference. And this is something really worthwhile to capture and show the patient. There's a 50% reduction of debris immediately post-procedure, and a 73% decrease in the Demodex load when combined with lid hygiene, compared to just lid hygiene alone. And there's a 97 times greater reduction in Demodex compared to lid hygiene alone. So we really see, and you can actually visualize that, and it's something that the patient as well can visualize and see that. So, when we're getting a patient prepared, now I personally do BluffX on every patient that's going to have thermal pulsation. When they're about to have thermal pulsation, where we're going to heat those eyelid margins up and we're going to express that meibum, I find it just the results that I'm getting really overall, patients very satisfied in cleaning those eyelid margins first. And I personally feel that you just get the optimum. So along with the eyelid margin, I mean, the meibomian glands certainly contribute to the tear film and produce the health that we need when we have an adequate lipid layer. And it's interesting when you describe that to patients, and I that's why I love meibography, to be able to show patients when you're expressing this to patients. They have no idea how important are the meibomian glands and really the role that they're. So there is some educational process, but when you tell them that this meibum really produces and what it's for is tear film stability, that it's going to help prevent and protect the aqueous layers, that it's going to help hold the tear together. Really, it's part of pre-op evaluations to help really hone down those refractive calculations for IOLs. When it comes to, you want that best accuracy. If you have an optimized surface and a more protected surface, then what you're going to look at is, your numbers should be something that you have a lot of confidence in. And poor quality tear film is a key indicator of dry eye. When we look at that tear film and we press on those meibomian glands and we see that it's a thickened, a turbid secretion rather than looking like baby oil. And I think it's important to explain that to patient. And, we talk about obvious versus non-obvious MGD. Well, if you press on that meibomian gland, it no longer is a question whether it's obvious or non-obvious. You're going to see, is it clear? Is it thin? Or is it turbid? Is it thickened? Is it paste-like? And so that evaluation is so important. And, when we look at this classification, evaporative dry eye, aqueous deficient, mixed, I have found in mine, I think I mentioned earlier, when we look at that continuum, we find that it is a constant continuum, that there's components of both evaporative and aqueous deficient. And the reason I say that is if we take a look at the consummate aqueous deficient patient, that would be a Sjogren's patient. And think back to your clinical practice. Have you ever seen a Sjogren's patient that has good meibomian glands? I'm still looking for my first patient that has that. So with that inflammation, with the Sjogren's, I mean, every patient that I've seen also has this evaporative problem, this MGD that goes along with it. So in my clinical experience, it really is this continuum, and patients have different forms. They accelerate a little faster, maybe in aqueous or in evaporative, and everybody's individual. So this mixed really tends to encompass what I see clinically as the majority of my patients. And we know from the Stern study that 86% of patients with dry eyes have clinical signs of meibomian gland dysfunction. So we know it's prevalent, we know it's out there. And when we take a look at how big of a part it is. So now when we roll back and we look at 35 million patients of the ocular surface disease patients that have dry, 86% of that number is tremendous. And when we think about the number of patients that are coming into your practice and the number of patients that you're seeing, how many of those patients really have this situation that you could have early intervention and help their ocular health? So when we say really there's no reason to wait, the patients are out there, and I'm going to show you that, we looked at the Microblepharo exfoliation or the BluffX. We know there's a procedure there that helps the lid margins. Now let's take a look really at what do we do about the MGD itself? So when we look at this MGD as a disease of dysfunction, and we see as we start to progress, as you look at this stage 1, you see this mild inspensation of the meibomian glands. The meibum isn't quite as clear. When you look at stage 2 and you start to advance, you can see that that's a whitish color. It should be clear. It should look like baby oil or olive oil. It should be very clear. And then, there's also these progressive stages in between this, between 1, between 2, and certainly between stage 2 and stage 3, as we see it continue to advance in stage 3. Now we're looking paste-like. We've really seen that we've reduced the quality of both the production and the quality of the meibum. So when we look at a Lash Cam and we look at the handheld meibography that we're seeing, or the meibomian gland imaging, if you will, if we look at the meibomian gland, that's showing the structure. That's showing the structure of what's going on with the meibomian glands. When you press on this, on the meibomian glands, now you're seeing the function. And the structure and function, just like in glaucoma, are what make up the disease entity. Is you want to see, what do the meibomian glands look like? What kind of dropout are there in there? What kind of glands are inspensated? What does the actual secretion look like? And again, then it's no longer going to be a non-obvious situation at that point when we're able to look and we're able to see exactly what the meibum, and think always in terms of, is this going to serve the function that we needed? Is this going to help hold the tear together? Is this going to help reduce evaporation? A great question when you see these patients is you ask them when it's cold, when it's windy, and you go outside, do your eyes water? Because that's a reflex tearing that happens because that tear is not staying together. It's not retarding that evaporation. The tear is evaporating much too fast. And it's a great question that you can ask your patients. When we look at TFOS-DUES-2, it supports in-office thermal pulsation to treat MGD at an early stage. Actually, stage 2 is where it's suggesting treat this, stage 2 dry eye. Now, the interesting thing, this was in 2017, roll back to 27, and there was not even the treatment of MGD mentioned in the TFOS-DUES-1. And 10 years later, in 2017, we see that it actually is recommending and supporting an in-office thermal pulsation treatment at a stage 2. And that just shows the awareness that we've had. It shows what we've really learned over the years and where can we put our efforts to make that patient as comfortable as possible and restore their health to their ocular surface, which then becomes so critical in anything we do, whether it's spectacles, whether it's contact lenses, whether it's a surgical evaluation or a surgical determination. Optimizing that surface is what's going to be incredibly important. And then let's talk about contact lens dropout. That also can be an incredible indicator, just as visual fluctuation. I think visual fluctuation of my dry patients is probably the #1 symptom. And this can happen when patients really don't have what we would typically think, the dry, the scratchy, the sandy type of feeling, because they possibly had a little down regulation of their corneal nerves. But the visual fluctuation, that won't stop. They will see that. That is a symptom that your patients can identify. So too is a contact lens dropout. And when I say contact lens dropout, it really is not just dropout, but no longer being able to wear their contact lenses as long and as comfortably as they'd been accustomed to. You figure the material didn't change, so something on the ocular surface and the physiology has changed. So when that patient no longer can wear their lenses as comfortable, that's when time to start looking and saying, is this possibly a dry patient with MGD? We know that with that visual fluctuation, how much that can affect somebody's ability, especially when we're looking at being on a light emitting device where we don't blink as much and we don't blink as complete. That can cause reading difficulty, both in looking at digital devices as well as hard copy. That can certainly affect individuals when they're driving, particularly at night, with the drop in contrast sensitivity and the possible dysphotopsia they get just simply from the dryness on the cornea. And then, of course, that fluctuating blurry vision with spending a lot of time. And, if a great example of that, if you're on an airplane, everybody's on a phone, a tablet, a laptop, and you see them, as you go to, or if you yourself are doing this in a dry air environment like that, how uncomfortable, how quickly that becomes. Well, that same environment takes place just with a lot of time on some type of a light emitting device with digital screen use. 55% is of contact lens wear self-report related dry eye. 55%. So, when we take a look at practices that treat a lot of contact lenses, the potential within your practice is 55%. And the best way to help determine that isn't just take this number. Actually do the market demographics within your own practice by asking those patients, have them fill out a questionnaire, really go after that information to find out how many of those patients are really experiencing that. And when 55% of contact lens wearers are self-reported, we know that that's prevalent, but find out what within your own practice, and that ability to perhaps help that patient and help that comfort within that dry symptoms really shows the potential not only to help your patients and provide a higher level of care, but also be able to show an alternative revenue stream within your practice. 23% of contact lens wearers discontinue contact lens wear primarily due to dryness, discomfort, and vision issues. So when we take a look at contact lens wearers, this 23% number says it's not a matter of if, it's a matter of when that patient will end up having to cut down their time where they no longer, and the discontinuing may not be that they can't wear them at all, but they can't get through their day. They can't get through their workday. They can't get through the social events. So when we take a look at contact lens wearers, if you have a contact lens practice, you have an ocular surface practice, and you have a practice that has a significant number of patients with MGD. So when we look at the Sustain Ilux, now we're looking at a device that is very portable. You can move between exam rooms. You can move between practices. Very, very portable. It is actually something that, and we'll show how you can customize the treatment. So based on, as you press on those meibomian glands, based on what you're seeing as you're doing the procedure, you can really give personalized care and optimize the results for those patients. So what this device did, and it actually was 2019 gold medal Medical Decision Excellence Awards in 2019. It warms the eyelid tissue to melt the meibum that is available to be melted, that is blocking the orifice, that is causing that obstruction. And then it applies gentle compression that the actual provider can control to express the meibum. And that's how we actually get the results of the thermal pulsation, by heating those meibomian glands up, melting and softening that meibum, and then gently expressing it. Because we know that as we look at these patients, that the acinar cells that are providing the meibum to this, they still will provide it. But if the meibum can't get out, that's when it starts to get thickened. That's when it starts to become obstructive. And that's when we start to get inspansated and the patient starts to increase in their symptoms. And how is this done? It's actually an LED heats the target tissue in 50 seconds or less. And it's not something that you have to count down. It's not something that you have to track. It's going to tell you how many seconds you're heating, how long you're actually going, and then doing the actual expression. So it becomes a very, very efficient in-office treatment tool. Again, it's portable. It can be taken between practices. It can take it in between exam rooms. So you see the footprint is almost non-existent, very small footprint, simply a recharging base. And the treatment, how long does it take? Typically 8 to 12 minutes start to finish when you get ready to go. Now, it also has a magnification. I said, you know, as you're doing this treatment, you want to be able to visualize, you want to be able to see what's actually happening and where you're getting the results. And if you have meibomian glands that just are heated up and you're not getting anything, you move on to a different area because you want to get the maximum results and get the maximum meibum expression to relieve that of the turbid meibum. So there's a magnification lens that we see up on the screen on the left that allows you to actually see the glands that are being expressed and visualize what's actually coming out. So you can see the expression and you get that response to exactly what you're doing, and you know where to continue to put that that time on those lids, what's going to produce, what isn't. And I always start out and I actually, based on my expression, I'll have a treatment plan. I know going in where I'm going to focus a lot of the time because I can see pressing on the lids where I'm going to get the greatest response. So first of all, you just put a drop of proparacaine or tetracaine in the eyes. Now this is actually the treatment tip, and you see it clicks on very easily onto the Ilux base. And then you want to position the patient. You can see, you know, the doctor is, Dr. Durker here is raising the patient up, getting the patient comfortable, head against the headrest. Get it where it's comfortable for you and the patient. So typically you'll want to raise that patient up a little bit so you can look through that sight glass. And if you look at the display, it'll actually it'll actually show you that where you're warming and how many seconds you're warming. And once you get to that optimal heat, when you get to that, 45 seconds, then you're going to switch. And you watch on the right hand on the thumb, he's actually going to, then you can see it. He actually moves the thumb down after it's heated and it's still heating up. You'll see the 45 seconds. Now it'll say switch to expression mode. And what'll happen is you'll move your thumb down. Now you're compressing. And you'll be able to see the meibum that is coming out of the and being released. So you'll visualize where you're actually being able to express. And then what you do is you go along several spots on the lower lid, and then you just flip the instrument upside down. Again, you can see through the magnifying glass, and now you're doing the upper lids. And if you're focused in the controls, still work the same way. You press on it initially to apply the heat, and it will tell you when it's heated. You can see that as it starts counting up, and then it'll say, time to express. You simply shift your thumb down, and again, you can visualize it. And this is something that, as you go through and you see this, what kind of time it takes, again, 8 to 12 minutes to apply that. And you develop your own technique on where you want to start, exactly what you want to do. But the important part is it becomes a customized treatment that you can actually see the results of where you're getting the meibum, what's being released. And I think that's such an important part. So let's take a look at this study. The study objectives really to assess the changes in meibomian gland function and evaporative dry eye symptoms after a treatment with sustained Ilux. So the primary endpoints were meibomian gland score. So we're looking at the number of meibomian glands yielding secretions, and then the tear breakup time. The secondary endpoint became the speed score and the OSDI symptom score. And these patients were assessed pre-treatment and at 1 week and 1 month post-treatment. And it was non-randomized, open label, and there was 30 subjects in this study. Now, what we see in this, and I think this is so important as we look at this, is 315% improvement in the medial, the temporal, and the nasal regions of the meibomian gland score. In other words, the glands yielding secretions and what those secretions look like. And the next number, does take a look at that, a 71% increase in tear breakup time. And we know small increases in tear breakup time can make a big difference. And again, this is at initially in 1 week, and all improvements were maintained at 1 month. The speeds questionnaire, or the standard patient evaluation of eye dryness questionnaire, a 53% improvement in all of the 6 subscores. And the OSDI, very similar results in that it was 58%. So when we're looking at 1 week, we're really seeing meibomian glands yielding secretions, tear breakup time, speed questionnaire, OSDI, all getting dramatic improvements, and more importantly, maintained at the level of 1 month. So then in a phase 4 study, we look at a 12-month follow-up of these patients. So this was to compare the endpoints of meibomian gland secretions, meibomian gland score, the ideal scores, and the tear breakup time. And this was assessed at 2 weeks, 1, 3, 6, 9, and 12 months. So it's really to compare the meibomian gland function and impact on dry eye symptoms on the patient's everyday life over 12 months of follow-up after that single treatment. The study design, again, randomized parallel group, investigator masked, multi-center, and it's a non-inferiority study. So basically it was looking at, is this the equivalent of thermal pulsation? So this study was really big, 236 subjects with MGD. And as we look, what we'll see on this is in the yellow line, that was the Ilux. In the white, it is LipiFlow. And we look at baseline meibomian gland scores, and we see this tremendous increase in both technologies. And then we see it increase at 1 month, increase at 3 months, increase at 6 months, level off at 9 months, and approximately equal then in 12 months. And if you see those lines, they parallel each other. They are so, and again, this was a mass study. So when the investigators were evaluating that, they didn't know which thermal pulsation the patients had had. So, clearly in meibomian gland scores, we're showing between Ilux and LipiFlow non-inferiority. And then when we're looking at the ideals SB score and the drop in that, and again, I think it's interesting to note that the baseline, and then at 2 week, and then a month, it continues to improve. So as those meibomian glands are free, you get more production. You can see it continues to raise on the meibomian gland score up to 6 months. And when we're looking at these symptomology scores, we see at 2 weeks, at 1 month, at 3 months, and now it's starting to level off, but at 6, 9, it's staying that way. And what's important is we see the non-inferiority. We're showing that the thermal pulsations are showing to be very, very similar, and shows non-inferiority. And I think this is a real important study for 2 reasons. It shows non-inferiority, but it also looks at a 12-month time period, because that's what our patients are asking. And this is over 236 patients that was done, and looking at this, how long it lasts, because I think these are important things that we need to pass on to our patients. What is going to be the length of time that you can expect results? When is the length of time that you may have to repeat the procedure? But you see the symptom scores as well as the meibomian gland scores are still really well elevated. When you look at the scores of 5 going up to 20 at 12 months, that's a significant difference on that. So we're really looking at, something that can offer and have an impact. So it's really looking at efficacy at 1 week. And by the way, you want to caution your patients when you've just done the procedure that the next day they may feel worse. They may feel more dryness, because it takes a while for those glands to start producing that meibum and get out to where they blink, they're actually holding that tear. So give them the proper expectations, but tell them that it's going to continue and maintain. And the studies have shown that it's at the 12-month mark still shows it. And we know that the footprint and how much space a device takes up in an office is particularly important. So we have portability, and I think the important aspect is it's really provider controlled. So we can really take a look and say, how do I apply this, and what am I going to do based on when I press on these meibomian glands and I see how many are inspissated that I can't get anything, and then you can heat that area up, and then you can move on to those areas that are more productive. The total time that we're looking is anywhere from 8 to 12 minutes, the total procedure time under direct visualization. So you're seeing this the whole time, real time. Now, there's also a program called DEEP. It's an implementation program and Sustain My Eyes patient retention program to really help you get started. I mean, so many times we get devices and we're enthusiastic and then they drop off. And I think it's really important that there's a program in place. Alcon is very vested in seeing your success within your ocular surface disease and within your meibomian gland patients. So let's take a look at a particular example here. This is Jane, who is a 46-year-old a female patient with MGD seeking relief, but still experiencing issues. So this patient, dry disease and blurry vision, speed questionnaire score is 19. Anything above 6 in my office is very significant, and we want to address and we want to do some of the point of care tests, and it's not adequately controlled. This doesn't surprise me with a speed score of 19 not adequately controlled on OTC, artificial tears, lid scrubs, and occasional warm compresses. And this problem's been going on for 3 years. So when we take a look at the meibomian glands, we can see atrophy, we can see tortuosity to these glands, we can see segmentation. So we know there's a problem here. So the assessment is dry OU, severe meibomian gland dystrophy OU, with gland truncation, dilation, and atrophy in both eyes, and then lash debris. And then we take a look at that tear breakup time. As we're looking at this and the numbers on this, the osmolarity in the right eye appears to be normal. In the left eye, it's high. You always do osmolarity on 2 eyes because a delta of greater than 8 indicates the disease entity as well. When we look at MMP9s, negative and mildly positive in the left eye, not surprising whatsoever with this appearance. Tear breakup time, 2 and 3 seconds. And this is going to be a symptomatic patient. And then when we look at the truncation, dilation, atrophy, 6 out of 15 and 5 out of 15 in the lower lid. So this patient really is experiencing quite a bit of difficulty. So let's, develop a treatment plan and look at the results 6 weeks post Ilux. The procedure, again, and I do this on every single one of my thermal pulsation, is perform a BluffX so I can clear the way, clear the debris, and have the most accessibility to those glands, and then perform the Ilux procedure. Now, the patient reports in symptoms, and now I talked about over 6 in a speed score in my practice. This is down to 6, from 19 down to 6, so very significant. We also have the patient using warm compresses and lid scrubs twice a day, as well as cyclosporin. All this and Sustain Complete is meant to help control the inflammation that we see with this patient. So when we take a look at the eyes now, we're looking at the conjunctiva and it's clear. Is there still MGD? Absolutely. You're not going to eliminate it. You're going to try and control it. But now look at the increase. It was two tear breakup time, 2 seconds, and now it's 6 seconds. And we see the increase as well on the left eye. The anterior chamber, deep and quiet, which we would still expect. Let's take a look at the diagnostic tests. Now, both osmolarities are within 8 milliosmoles and right around 300, indicating normal. And now the MMP9s, or the inflammatory, is negative on both eyes. And now we're looking at this number of glands that have, and the meibomian gland score has more than doubled on this patient. So 6 weeks post, you see all of these both objective and subjective improvements that have occurred for this patient. And we'll take a look at another patient, 70-year-old male, And this is preparing the ocular surface for cataract surgery. This is such an important aspect right here. So patient complains of blurry vision. Well, they have a cataract, so I would expect that. No significant past ocular history. So pre-Ilux, moderate lid ptosis, mild to moderate meibomian gland blockage, and decreased tear breakup time, and PEK in the 2 to 3 plus range. When we take a look at 6 weeks post Ilux, lids, again, same ptosis they have, minimal meibomian gland blockage, and cornea and SBK trace inferior in both eyes. But what's really important is when we look at the keratometry. Why is the keratometry so important? That's what is one of the key indicators that's going to go in that's actually going to help select the IOL. So when we look at the keratometry, pre and post, we can see the changes that actually occur. When in the right eye, there's a small change. In the left eye, more of a significant change. And particularly when we look at the axis, we see in the left eye how much that axis has shifted, because now you can get more accurate K readings, which then goes in to the biometry to help really determine what that power of lens is going to be. So when we look at the different methods of calculating and what's going to happen on, as far as what the cell looks like, you can see the TCA, the lens star, and how that varies on that left eye in particular. The right eye, not quite as much, but the left eye fairly significant. When we look at the change in imaging following the pre and the post, you can see the skewing and the turning of that axis on that imaging. And again, what this is going to mean is you want to optimize the surface to give that patient the best results that you can possibly have. And when we look in the left eye, this one was the right eye, and that is the left eye. That's where we see that significant change in axis and in magnitude. So when we look at taking control of patients' ocular surface health, using that DEEP program where Alcon really helps you, and the My Eyes program with Sustained, it really is looking at personalized procedures. How are we going to maximally benefit this patient? And by providing a higher level of care in our practice, helping that patient optimize the surface, whether it's contact lens, whether it's pre-surgical, helping that patient is also going to help the revenue of the practice. So making a patient, adding that care, having a higher level of care also is making the practice healthier as well, by adding that personalized procedure of the BluffX, letting them see with the Lash Cam that helps drive the procedures, doing the BluffX as well. And the BluffX can be a standalone procedure also. It doesn't have to be just only when you do thermal pulsation. And it really is such modern technology, and really an investment in your practice that is going to continue to generate revenue sources, which we've seen decline through reimbursement. We saw it in the pandemic with contacts and spectacles more and more going online. This is a chance to really shore that up within your practice. Just the information, the BluffX is really intended for exfoliation and debridement of the eyelid margins, and it can be a standalone product and a standalone procedure. It is within my practice. The thing that you'll really find impressive is how good the patients feel. They will report to you that they do feel better. And when we're doing the Ilux, and this indication for the Ilux is applying localized heat and pressure with those patients with meibomian gland dysfunction, as we see those patients, and as you saw from the studies, the phase 3 and the phase 4, how it maintained for 12 months and how it continued to improve. And when we look at the patient satisfaction scores with the symptoms and what a decrease going from a speed score of 19 down to a speed score of 6. So I'd like to thank you for attending this session.